To give a recap of the reproductive health program and policy as it has evolved over the last some decades, perhaps I'll start with what was the first and most important milestone, which was the International Conference of Population and Development in Cairo in 1994, in September of 1994. This was a major watershed in the field of reproductive health. And at this conference, which was a global conference, the nations of the world came to a consensus, a very important consensus, that if countries were to pay greater attention to the education of girls, the health of women, the survival of infants and children, and in general the empowerment of women, and also provide a set of reproductive health services, comprehensive services to address the reproductive health needs of people, major strides would be made, both in terms of social equity as well as in terms of reduction in population and fertility. This was a major shift, which we called a paradigm shift actually, away from what had been in the past a population control approach, a top-down population control approach, often with contraceptive specific targets which were frequently very coercive and therefore against reproductive and human rights, towards an approach that was concerned with the needs of the people, with the reproductive health needs of men, women, and adolescents. And the idea being to move from a top-down, demographically driven target approach to a client-centered, gender-sensitive approach to address reproductive health needs. So there were some 183 countries that signed off on the program of action that was developed at ICPD, which in groundbreaking language endorsed the concepts of reproductive and sexual health and rights for the first time, and designed a pathway for achieving those ends. Now, India was one of the signatories to this. And it's very interesting that as soon as the delegates from India returned from the conference, they decided to adopt the policies that had been articulated in Cairo. So, the government of India and the World Bank formulated a committee that would undertake a sectoral approach, an examination of what was the state of the art in India and which way India should move. And there were a few people in that group that formulated that formulated this program in the end, and I was one of them. So, in 1990, this was set up in 1994, same year. They came back in September and November of 1994, this was set up. In 1995, the World Bank provided a report to the Government of India, which was entitled India's Family Welfare Program Towards a Reproductive and Child Health Approach. The Government of India accepted the recommendations and decided to implement a reproductive and child health program. In other words, to change policy. The reproductive and child health program was implemented in 1997. And in 2000, the national population policy was articulated, framed and articulated. So there was a sequence of steps which took place in succession, quite rapidly in fact, within a very short span, to make this policy shift, the paradigm shift, from a very different top-down approach to a client-centered, gender-sensitive approach that was a comprehensive approach to not only achieving demographic goals, which was one of the objectives, but also to enabling couples to decide freely and responsibly their their desire for what number of children they should have, and when they should have those children, and how. So it was a freedom of choice basically that was provided through this process. So in other words, the ICPD agenda required therefore not only a policy shift for the government to make, and the Government of India agreed to do so, but also to provide a set of services that could make that change happen. And a package of reproductive health services, an essential package of reproductive health services was designed in place of the only family planning program that was receiving attention thus far. Family planning was an essential component and a central piece of that package of services. But there was a clear recognition that in addition to family planning needs, people had other reproductive health needs, and therefore all of those needs needed to be addressed. And in fact, even to address family planning needs, you had to address the other health needs. To effectively address family planning needs, you need to address provide other services as well. This reproductive health package of services was designed by me, and I'm very pleased that it was accepted and included within the reproductive child health program. In fact, the language was more or less repeated in the document of the Government of India, which was very encouraging. So, this was meant to happen over a time period. One recognized that in India there was great diversity in the way services were delivered and in the health infrastructure that delivered the services in different regions and states. And therefore it was proposed that this package of services, while it should be implemented nationwide over a 5 to 10 year period, should be phased so that it was feasible. And there were a couple of principles that were articulated. One was that, if you had to decide to deliver the services, the entire package should be delivered, because there was a synergy in the services. Each affected the other. And to be effective, the entire package needed to be delivered, rather than to deliver it piecemeal. So if in an area it was not possible, you could do it in an area where it was possible and feasible to do so. The second thing was that there was a concern about costs. And frankly, we worked out some of the costs, and the World Bank assisted in that process. The services that had been recommended in the essential package of services were the most cost-effective services. So that was not so much an issue of cost of providing those services. The real cost would be of strengthening the system, of providing the human resources that were missing, and so on. And the third factor was that the services that were included in the essential package were not new. Many of them were already in the primary healthcare system. So it meant really providing them in an integrated fashion and ensuring that the quality of care was improved. The service quality was a critical issue. Now, what did this package consist of? It was services to prevent unwanted pregnancy, family planning, abortion services, services to promote safe motherhood, services to improve infant and child survival, services for adolescents whose needs had never been addressed or not even been assessed at that time, and gender sensitive, sexuality sensitive services, because HIV/AIDS had become an issue and we had so far not touched the issue of sexuality and gender, and these were essential elements to be incorporated within the package of services if it was to be implemented effectively. One of the arguments that I made when I recommended this set of services was that we need to implement these in an integrated way. Thus far, what was happening was, and it still is happening in fact, is that services are provided vertically. They are funded by different donors and implemented through different departments of government. And when that happens, there's fragmentation, there's duplicity, and there's a waste of resources, actually. So the argument was that both from the cost effectiveness side as well as from the effectiveness of the services side, it was important to converge services because people have multiple needs, multiple reproductive health needs, which therefore need to be addressed in an integrated fashion. They shouldn't have to go to 10 places for 10 services. That certainly is not cost effective. That is something that took many years to be understood. I think it was understood, but to be actually operationalized. And now we are seeing some glimmer of it at this juncture, but to a limited extent, I think.